valve replacement, and I will just go through how we are doing it and how we have evolved over the time. Actually, what we have done is mostly from the last 2 years or 2.5 years. A few isolated cases we had done a few years back for pediatric patients. So these are the points which I'm going to cover. How it is being done, I will be showing a few videos, and we are just showing a few results about 2 centers. One of the surgeons who is also at Hyderabad, and he also does in the pediatric and the adult population. So these are the few important steps which are very essential when we are planning for an aortic neocaspidization. Harvest and preparation of the pericardium, sizing of the annulus, preparation of the leaflets, then suturing of the leaflets, fixation of commissures, and also checking of the valve. So this is the type of anatomy which we have been selecting over the time, like it's especially in the beginning of starting this. You can see that it is a not so calcified valve, and you can see this more of a thickened, and it's a rheumatic type of valve, which is a tricuspid valve. At least in the initial stages, we don't do bicuspid valve, and especially what we have seen is the annulus should be relatively free, so that you don't have too much of difficulty in suturing your neocusps. Now the other video which I would like to show is how we harvest the pericardium. Now most of the it has been taught that you have to harvest with a low electrocautery. But what we have seen in some of the videos and in some of the papers, that it is better if we harvest with the harmonic scalpel, because it doesn't actually cause any heat injury to the pericardium, and so that your pericardial tissue is well protected, and you can also remove the fat and all at the same time with the harmonic scalpel, and then take those stay sutures so that you can use it for fixation of the pericardium. Then this is how we fix it with the regular way. It is like 0.6% glutaraldehyde, and just for a few minutes, or who has seen this are aware of. So then the next important step which I would like to very stress on is formation of the commissures. Like, you should have the adjacent leaflets at the same level, and then fix them very securely by adjusting their coaptation line, so that that gives a very important stability to our neocaspidization. So this is how we are fixing the standard way, where we take the pericardial plates on the outside, and then with the 2 sutures, so that it stays secure. So this is the final result. This picture, I think everyone is aware of. This is how it should look like, and at the end of the procedure. Then we do a rough checking of the valve by just putting a little bit of saline onto it. There are other ways of checking it, like you can suture a graft around it, so you can give a little more hydrostatic pressure and see if it is leaking. So most of the time, if it works, then the final checking will be once you are coming off bypass. So I would just like to once this come to how we had evolved, like especially in our center. Like in the initial stages, we had done a procedure something like this in a few pediatric cases. Like one was a patient who had already undergone a subaortic membrane excision, but he came with a recurrence, and he had an associated coaptation, so we had to do both the procedures at the same time. So we had no option because he was a small child, and we were not thinking of replacing his valve. So we took the bovine pericardium because he was a redo patient and we were not having sufficient pericardium. And we did an extension something like this, a few cases, 1 or 2 cases only, and it worked well. basically it was a tricuspid valve, only his leaflets were not sufficient enough, so we extended it. So this, somehow this is a picture how it looks like when this procedure initially we were not, no, especially in the pediatric group, I think most of the surgeons who are doing the pediatric work also, they use a suture, a silk, and then a silk to measure the annulus, and then what they do is they make a cusp out of it by taking almost like 1.5 times the length of the annulus, and then roughly make a leaflet according to it, and then